Hello and welcome to everyone on this chilly Thursday evening. If you're in Canberra, I'm sure it's somewhere around 0 degrees about now. It's fun to be indoors today. My name is Chrysta and I'm the ACT Chair for the Australian College of Nursing. I'd like to welcome you to our presentation this evening with BEAT Bladder Cancer Australia, a patient perspective. In the spirit of reconciliation, I acknowledge the traditional custodians of the land on which we meet this evening and their connections to land, waters and community. I acknowledge the stories, traditions and living cultures of Aboriginal and Torres Strait Islanders people on this land and commit to building a brighter future together. I pay my respects to elders past, present and extend that respect to Aboriginal and Torres Strait Islander people who may be joining with us today. Getting on to the logistics of today, we've got a little run through that we'll do, and if you want to pose some questions to our group, we do welcome any questions or chats that you want to pop through. There's a question and chat function just on your toolbar. If you just pop any questions in, then I can raise them with the group and we can start some discussion with the panelists. So please feel free to pop through anything that you want. And I'll now hand over the presenting to Dr. Kalli Spencer. Enjoy.
Thank you so much, Chrysta, and thanks again for hosting us and inviting us to present to the Australian College of Nursing. We do appreciate this opportunity, and we really enjoyed last week's or the previous session that we had, and we had some great feedback, so thank you for that. And I'll pass it on to the team. And I'm joined today by a new group of people, very special people. I have so firstly, myself, if you weren't in the previous session, I'm Dr. Kalli Spencer. I'm a urologist by training and I'm based in Sydney. I'm joined this evening by uro-oncology nurse Helen Anderson, who's from the Gold Coast University Hospital, and she has a very particular or specialized interest in the patient journey, particularly oncology patients. And then a very special warm welcome to our stars of the evening, our special guests. I have Christine LaRose, and maybe she'll just wave, although you'll get to meet them all later. I have Peter Haggerty, and I have Richard Green. So these are our patients. They've taken the time out of their evening to come and share their stories with you. That's what this evening is all about. It's all about narratives and sharing a patient journey and what they've been through, or what they're currently going through along their journeys. Feel free to engage, to ask questions. They're used to that. They've chosen to be advocates and to represent the bladder cancer community and share their stories to help others along the way, or those that are just starting out on their journey. So these are very special people, and we really appreciate them and thank them for doing what they're doing. And let's bear in mind that these are their personal stories, so whatever stays within this session, whatever's discussed in this session, may please stay in the session, and let's not share any of their personal information out in the community. Our same codes, ethical codes as practitioners apply here in this session. And that's sort of how we run our support groups as well. So if you're not a patient or a carer or a healthcare professional, ideally you shouldn't really be watching, but if you're any of those, welcome. So yeah, I'm not going to harp on too much, but jump straight into the presentation. So BEAT is, like we said last week, BEAT Bladder Cancer Australia. That's our name, standing for Bladder Education, Awareness, and Treatment and Research. And our mission is to increase community GP and health professional awareness and education, to provide support and services to the bladder cancer community, and also to steer and advance bladder cancer research, diagnosis, and treatment options. So for this evening, we're going to have a little intro. We're going to tell you a bit more about BEAT Bladder Cancer. Then we'll tell you a bit about how our support group works and what we do in our support groups. And then we're going to jump over to Helen, who's going to tell us about the role of the uro-oncology nurse and her role in the patient's journey. And then we're going to hear from the patients themselves about their journeys. So just to remind you, our website is set out as if you're a patient starting out on a journey, and that's what kind of symptoms you'll be experiencing when you start out, and then what you can expect when you go and see the GP firstly, and then when you go and see the urologist. We've got information about your treatments, the treatments that are available depending on your stage. And then we've got links to all kinds of support, whether it be psychological, whether it be physically, whether it be health, nutrition, exercise. So all of that's there, or whether it be for advanced care and palliative care, end of life care. So that's our website again, in case you didn't get it last time, beatbladdercanceraustralia.org.au. That will be the landing page when you arrive at the website. As an organization, once again, we're trying to get the word out there, raise the profile of bladder cancer. It's number 11, the most prevalent, it's the 11th most common cancer in the country. So yeah, it's not the top 1 or 2 or 3, but it is common enough, and it certainly is a very complex cancer to treat and an expensive one to treat because the follow-up is so complex. So it is important for people to know about it. And if you pick it up early, you can treat it. Early detection does save lives, and that's what our campaign is all about. We have fundraising initiatives. We run a walk in May for Bladder Cancer Awareness Month every year. Try and make ourselves visible in the marketplace. We've got banners and adverts in shopping malls, and we've been to a lot of the health professional conferences. You can see our team there at a table. We have a whole range of brochures and information that you can take with you to put at the GP's office or your urologist's office or out in the community. Just everything in the hope to raise awareness for bladder cancer in this country. And about our support, so I'm joined by Christine, who is a patient that also helps me run the support group. It's a patient-led support group, patient-managed support group for the patients. So is the whole charity. And you know, they drive all of this. And as healthcare professionals, we come in and offer support. We find guest speakers, health professionals and speakers, and we offer medical advice to the group. So our group is the last Tuesday of every month. We started in Sydney initially and just locally, and then COVID came along a few months later, and we were forced to go online. And then we realized, well, why are we keeping it local? We might as well go nationally. So we started up the first ever national virtual support group, which we do on Zoom. We meet the last Tuesday of every month, 7:30. We always have a guest speaker who's ranged from urologists to oncologists to pathologists to all the allied health teams. We've had urology, oncology nurses as well. And they talk about important topics to our patients, anything from stoma care to nutrition after surgery, to getting ready for surgery, to just how the bladder looks and how does it work and what does it look like under the microscope, to what the pathologist sees under the microscope and how they stage the cancer. So we have really great discussions. All the patients have a chance to ask questions and engage with the speaker. And then the second half of the session is just our support group, where we just have the patients alone. We have our existing members, we catch up with them. We see where they each are on their journey, and we have a record of you know, what their journeys are about. And then we welcome in new members, people that have just started, wherever it may be on the journey. Some are right at the beginning, some are in the middle. And we welcome them and we listen to their stories, and then we exchange. We allow the existing members to share their experiences and stories with the new members. Some may be needing to go for surgery, for cystectomy, bladder removal, which is a huge operation. There's a lot of psychology behind going for something like that. And we, with the help of the existing members who've been through that, they can show that it wasn't all that bad, as you'll hear tonight. They got through it, and these people can get through it too. So there's huge peer-to-peer support that goes on, and that is just so important for people that are newly diagnosed. So that's our support group. That's how it kind of works. That's how it runs. If you have any questions, feel free to ask. at any time. The other thing we do is we also are able to connect people that maybe don't want it. Not everyone wants to be in a support group. Some people have social anxiety, they don't want to be in a group, or they don't want to share their stories so publicly. So we connect people privately to other patients that are similar, maybe had the same surgery, or they also got a near bladder, or they're going to have a near bladder, or they want a younger male or younger female, or they want someone that lives near where they live and they might be able to meet up. So we offer that service, that we can connect patients one-on-one and exchange contact details, and they can talk in their own time. So yeah, if anyone is interested, when this COVID goes away, to actually starting their own local support group, because I mean, virtual is good, but everyone loves face-to-face, to be able to maybe hug your participants, or you can read each other's emotions better. There's so many benefits to face-to-face, and not a lot of older people aren't comfortable with the technology, and they might be missing out. So there's still benefits in face-to-face support groups. And if you're interested in starting a local chapter, we're there to support you and help you. So please reach out to us, and we'll give you our details later. We are endorsed by the Cancer Council of Australia, and they also run a similar Cancer Connect program, and that's their number. I'm sure you're aware of it. They also have an Understanding Bladder Cancer booklet, and we work very closely with them. And very often they ask for our patients to be the ones that connect to newly diagnosed people. So these are our collaborative partners, as we said before, the Australian College of Nursing, the Cancer Nursing Society of Australia, ANZUNS, which is urology specific, and then the surgeons are part of the USANS, Urological Society of Australia and New Zealand. As I said, Cancer Council, and also we have a relationship with the Rare Cancers Australia, because some of the bladder subtypes, like adenocarcinoma and squamous carcinoma, are quite rare and affect younger people, and the needs are quite specific for those patients. So that's where rare cancers come in. Just wanted to, before I finish my bit, to give you some feedback from previous sessions. Sorry about the IT glitches. Last time, as you can see, we've corrected that. We've got everyone's faces now, and everyone can hear and speak, which is great. Don't feel so alone, which is lovely. So we sorted that out. There was a question about post-surgical hematuria and anticoagulants, a big problem, as nurses you will know. As wonderful as anticoagulants are, they save people's lives. They do. They prevent heart attacks and strokes. But yes, they are also the bane of the urologist's existence, because they do cause bleeding and bleeding and bleeding and bleeding and bleeding that doesn't ever stop. So obviously, yes, it's a balancing act. We've got to get the hematologists on board. We do need to stop them. If patients are on warfarin, there are ways to reverse the warfarin. The other anticoagulants, the newer ones, unfortunately, there's not many options available to reverse some of them. You could look at giving things like fresh frozen plasma, or some of the factors. So that is an option. Otherwise, it's just irrigation, and very diligent irrigation without it ever stopping. And eventually, once those anticoagulants wear their way out the system, the bleeding does eventually stop. All bleeding does eventually stop. So sometimes it necessitates a trip back to theatre for a bladder washout, or we need to find where the bleeders are and cauterize them. So sometimes we do have to do that. But in most cases, once the anticoagulant wears its way out the system, then the bleeding stops on its own. And for some medications, that can be up to 7 to 10 days. So yeah. For retractable hematuria, so it's just nothing's responding. There are agents you can put into the bladder, such as alum, which the pharmacist can prepare for you, or the doctor can order it, and you can actually put that into the irrigation bags, and it has a local topical effect, which helps to stop bleeding. So that is one consideration. Someone had mentioned someone has had radiation cystitis. So radiation causes quite significant bleeding, and hyperbaric oxygen is certainly an acceptable form of treatment. The patients would have to have several sessions for that, which may or may not work. a last resort if you start looking at things like putting formalin in the bladder, which obviously can be quite damaging, and it really truly is a last resort. So yeah, hope that answers the survey questions that we had from people in the last session. And once again, to remind you, this is our email address, and we are really looking to send out our brochures as far and wide as possible across this land. So please email us your email address, and Christine over there in the corner, who is working day and night like Christmas elf, she will send out those brochures to you wherever you are, and you can display them in your wards, in your outpatient departments, in your doctor's office, wherever, everywhere. We want everyone to see our pamphlets, so please do email us. And I think that is it from me. That's said enough. I could talk all night if I had given the chance, but let's let someone else talk. So I'm going to hand over to Helen Anderson, who's going to tell you more about the patient's journey from a nursing perspective, that holistic care that us as doctors are not that good at. We don't have the time to talk to the patient, but nurses do. You talk to your patients and you listen and you pick up all those psychosocial things that we don't. And that's why we love you for it. So I'm going to hand you over to Helen to tell you more. Thank you.
Thanks, Kelly. Can I just check my screen is showing?
Yes, it is.
It is, okay. Sorry,
you can just put it in presentation mode there at the bottom. Yep. That's the one. Yeah.
Is that
so
one?
where you were? Yeah.
Okay.
You just need to click on it. That one at the bottom there. Yep, that one.
Okay,
Perfect.
there we are. Sorry, I do apologise.
Go ahead. No worries.
Thank you, Kelly, and this is great. Thank you so much to the Australian College of Nursing for doing. I know they've done the 2 sessions now, so it's so good to get some more bladder cancer awareness out there, obviously. And from a nursing point of view, it's a huge thing and a huge benefit for us to have BEAT that we can refer patients to as well, because in the past, many years ago, we didn't have any support for these patients really. So it's so good to have BEAT Bladder Cancer now that we can actually, you know, patients have got a bit more support out there in the community, which is fantastic. So I don't want to take up too much time tonight because it's about the patients tonight. It's not really about me. So I just quickly want to briefly go through some of the nursing considerations for when we're looking after patients that have been diagnosed with bladder cancer. And my background, I guess my role at the moment is more related to patients having medical oncology treatment, so chemotherapy in the neoadjuvant space or in the adjuvant space after surgery, or in the advanced bladder cancer stage where we're doing immunotherapy and things like that. But previous to that, I spent a lot of years working in the surgical space as well, with patients having cystectomies and having to have BCG. So I'm just coming from a bit of a varied background. So important things from a nursing perspective, and particularly in our role, is that we do that initial assessment when we first meet our patients. So not just an assessment of, you know, their physical symptoms, but what else is going on in their life at that time, socially, psychologically. It's usually those things that are more stressful to patients, we've found anyway, than the actual diagnosis. It's the impact that diagnosis is having on the rest of their life. So it's just that ongoing, that assessment that we do initially, and then just checking in with people along the way as well. I'll go through these in a bit more depth in each slide as I go through, but as I say, I'm not going to go too in depth this evening. I'll quickly talk about, you know, referrals to allied health. It's a whole team of people that help support patients, obviously their families as well. So it's just, we don't just rely on one person. There's a whole team out there that help people get through their surgery and their treatment and then into survivorship and things afterwards. I'll briefly talk about some of the education and information that we go through. Coordination of care is a huge part of our role. Often patients, you know, they're coming to urology, then they might be referred to oncology, then they might have to go back to urology, back to oncology, you know, and scans in between, maybe they're having scopes in between in different services. So it can be an absolute minefield of appointments and different services. So it's just coordinating and helping just guide patients through that as well. And in our role specifically, we've just become a constant for that patient. So whichever service they're under, they've always got us to ring if there's anything going on. And I know it might be a little bit different in the private, because I know obviously patients in the private might have access to their oncologist or urologist regularly, but it's very different in the public where they don't get that access to the doctors. So we're just a constant right throughout the treatment and even after treatment as well, just as a contact for them to ring, and if they've got any questions or they're worried about anything. So I'll just start with this. This is the biggest thing for us nurses, I think, is to stop and listen. We've got so many things that we want to tell the patient. So they've just seen the doctor, they've just been diagnosed, they've been told the treatment options or the different things that, you know, are going to happen to them. And we want to elaborate on that, and we want to give them all this information and make sure that they understand it all before they leave the clinic that day. And I think, you know, at the moment now, it's just, this is the time to stop and just go, right, okay, we need to go back and we need to just find out what are the patient's main questions and what are their main concerns. I've had patients say, you know, what's your biggest concern? Well, it's my dog. Who's going to look after my dog if I'm coming in for surgery and I'm going to be in hospital for 2 weeks? Or, you know, what am I going to do for money because I work full time and now I'm not going to be able to work? So often it's those things that are more important, and it's those things we need to address first before we do anything else. So I think part of our nurses' role is that that's a huge thing that we need to do when we use distress screening in oncology, just to, as a patient reported form, they write on there what is their main concern, and then we work from there. So everything's tailored to what they actually need at that time rather than whatever we think that they need. Just briefly touch on health literacy. It's a big thing in the hospitals at the moment that, you know, 60% of people, the general population, we have poor health literacy, and that's not that we don't understand, we can't read or write, or we don't, you know, we're not clever. It's just that people don't understand the, you know, the access they've got to different services, feel confident asking questions in a consult, understanding the jargon that we use in the medical world. So I think it's just working with that as well and making sure that we aim everything at the level that that patient's at, so that we're not overburdening with a load of information that they don't understand. So I just wanted to make that point, that addressing those things first is probably the most important part of our role, and just stopping and letting the patient breathe before we launch into loads more information that we need to give them. I just briefly, just about the different people involved in patients being diagnosed with cancer, you know, obviously the psychological impact is huge. We're very fortunate at the Gold Coast, we do have an oncology psychologist that we can link patients in with, so that's really good. But even community services and things like that, you can link in with the GP to a healthcare plan, and they can get a mental health plan through that and get a psychologist and get 5 free sessions, I think. So it's just to think about those things, but I won't go through them all. I mean, you know, if patients are going for a cystectomy and they're going to have a stoma, then involving the stomal therapist early on to do the education and go through and make people feel confident about what's going to happen to them, understand what's going to happen to them, then it's not as scary then going into the surgery and managing that afterwards. And I'm sure Christine and Richard and Peter will talk about that later, but you know, even pelvic floor, if patients are having a neobladder, it's doing all that pelvic floor training and exercise before the surgery, and you know, just preparing. So it's all that preparation for things, and that's where that whole team support comes in. Just touching on the education information that we would go through, and just again, just making sure that the information that we give is for that individual person. So you know, we just give out booklets willy-nilly in the clinic, but some people, you know, I've had patients that actually can't read, so that's not, it's just finding out how patients understand things more. So I know that on BEAT they've got the video links and they've got written information, which is really good because it means people can choose what information they have access to in the format that they've got it in. So that's pretty crucial. We'll go through side effects of treatment as well. So with just a quick example with BCG treatment, you know, it's just, you know, there might be some pain and discomfort after you've had BCG into your bladder. and it's going through ways to manage that. So drinking plenty of fluid, keeping yourself well hydrated, and when to report things that are probably not right. So it's giving those people to empower them a little bit to manage those things, so they don't feel so dependent on healthcare professionals, and they can, you know, feel a bit like they're in control of what's happening. So it's giving them the tools to be able to manage things, but knowing, so that they know when to ring and when they think there is a problem, that they've just got someone that they can call and contact. And the side effects to all the treatments, you know, chemotherapy, surgery, there's obviously side effects post-surgery with the bowel and things like that, that people need to be able to be aware of and manage, so it's not so daunting afterwards. Sorry, I'm rushing through this, but there's a lot about prehabilitation as well out there at the moment, and I haven't spelt rehab wrong. It is prehab, and it's all to do with optimising people's health before they have surgery, really. So cystectomy surgery is huge. It's, you know, it's a long surgery. It takes the toll on people physically and emotionally, and it's just optimizing people's health in regards to nutrition optimization, exercise, getting their lungs and their heart ready. One of our urologists used to say, you're going to get ready for a marathon, you've got to get your heart and your lungs working, and you know, you're training for this, really. You're training to go into this surgery. You know, helping with, if people are smoking, maybe just helping with stopping the smoking, just and psychological impacts as well, so helping them with that, just so they're at their best, so that when they go into surgery, often they recover a lot quicker if we optimize their health beforehand. And then obviously we're going into recovery and survivorship, and survivorship is a huge thing in cancer at the moment, that we put all these patients through treatment, and then we, you know, we wave them goodbye and off you go, and you get on with your life now. And that it's not as easy as that. There's the fear of recurrence, there's all the symptoms and the side effects that they're living with, that they'll live with for the rest of their lives because of the treatment that they've had. So we have to sort of make sure that we support them right through, and that we don't just, you know, wash our hands of people when they go into that survivorship space. And obviously giving them information about support services, so BEAT, Cancer Council, you know, and any local supports as well that might be available. And the last slide is very messy, but I just wanted to show the complexity of, I mean, it's anyone really going through a cancer diagnosis, but it's very particular as well to patients diagnosed with bladder cancer, just because of when you look at the treatment sort of area, the things that people can be actually having. So, you know, they can be having pretty harsh chemotherapy, and then going for huge surgery within a short space of time. So it's a massive undertaking, and I can't even imagine what that does to somebody's body and how they get through that. So, but this was just to look at the gaps in care and where nurses could slot in, you know, and where we might be missing things. And it's just good to see what this is, the whole muddle of what people have to actually navigate when they've never been in the health service before. So we are that guide, just to guide them through that pathway, and when they need us, we can be there to support people. And that's really it. I didn't want to take too much time, so thank you, and happy for any questions.
Thank you, Helen. Are there any questions? I haven't seen any pop up now. You raise a very important point there, Helen. In one of the last things you said, you know, with bladder cancer, they go very quickly from chemotherapy, that stress of chemotherapy, to the stress of this big surgery. I mean, that is quite, and then you're dealing generally with an elderly population as well, who have multiple comorbidities. Most of the bladder cancer patients were smokers in their past life as well. So you've got all the COPD and lung issues to deal with as well. So, sorry, I'm trying to do two things at once. So you've got all of that. So there's a lot going on. But we'll talk more about that now when we talk with our patients. So the one thing I forgot to mention in the support group, which is quite nice, you know, it is nice to see everyone relaxed in their home. Some people bring wine to their support group. Many have their pets with them, which I think pets are great for people on a cancer journey. And then they have their partners with them. and the partners form part of this journey, which is really, really good. And they're there in the virtual support group with us. And it really is like a little family. You get to know a lot about each other's lives. So yeah, without further ado, let's jump straight into the patient experience. Now, can you see my screen, Chrysta? Is it now presenting the patient presentation?
Yes.
Okay, good. That's great. So what we're going to do is we're going to start. Last week, you'll remember we spoke about sort of two major divisions for bladder cancer. There's the non-muscle invasive, and then there's the muscle invasive. And the non-muscle invasive cancer means generally, it's not invading the muscle, so therefore it is amenable to topical treatments. So what do we mean by that? Chemotherapy type agents, whether it be BCG, whether it be mitomycin, and that there's various few other agents as well, epirubicin and the like, that we can put into the bladder through a catheter, and it has an effect on the growth of those tumor cells, prevents the cancer from recurring, prevents it from progressing, the BCG. So our first patient coming up has had non-muscle invasive cancer, and we're going to talk about the experience of having this treatment. So Richard Green. Hi Richard, how are you feeling?
Yep, a little bit nervous, I must say. I haven't done this for quite a while. Yeah, I know
nervous?
it's not usual. I know.
No, you're such a confident speaker.
Yeah, well, I just feel it's a very serious thing that we're talking about, and the reach out that BEAT does for each one of the patients that you're involved with is extremely useful, helpful, and the more that nurses get involved and know about it, the better it is. And I certainly personally want to thank every single person that's listening into this and watching for participating, because I think it helps patients like me understand that people do care. So I'll get started, shall I?
Yeah, I want to know, firstly, where you're from, Richard. Where do you live? Who's your support?
I'm from sunny Adelaide, which is cold and wet right now, and in lockdown. I live with my wife of 30 years. We've just sold our house and we're now living in a one-bedroom apartment overlooking the water while our new place is being built. So things have been up in the air, but that move was caused by the fact of me getting cancer and rethinking our lives and moving forward. So, yep, and the fact that I do have 10 children as well. So that kind of, we're downsizing so they can't fit in.
Well, 10 children, a lot.
Yes, 10. I have a stepdaughter and then 9 of my own children. So yes, a big family. And yeah, it was good when we got back. We just got back from a holiday to Queensland, got back just in time, and immediately they all came round and gave us hugs and kisses and made sure we were okay, and it was really cool. So yeah.
That's good. And Richard, so how did you know originally that you had bladder cancer? I mean, were there any signs or symptoms?
Okay, well, it all started, I suppose, we were on a cruise with some American friends from Sydney to Tasmania, and I had a need to go and pee every 5 minutes, and it was very embarrassing. And as soon as I got back from the holiday, I went and saw my local GP, and he diagnosed me with a UTI infection, which I can't ever remember having and before. And so he treated that with antibiotics, and then it moved on to, that was in the February, and then almost leading up into June, I had another one. But this time I noticed there was blood in the urine, so I went and saw my GP again, who was again about to put me on to antibiotics for a UTI. And I said, no, look, this doesn't seem right to me. I want to take it a step further. And so he referred me to a urologist. and because I'm in the private system, I was lucky to get an appointment about a week later, and saw him. He ran some tests. Cancer cells showed up in the urine samples, and went back and saw him for those results. Booked in for the very next day for a TERP, and that's when it all sort of come crashing down around us. Wasn't prepared for that, you know.
So what kind of things were going through your mind when you got this diagnosis?
I don't get sick. I'm a retired builder, and I hurt myself, but I don't get sick. I don't get colds very often. I don't get ill. So to suddenly have something wrong with me that I couldn't physically see or have to deal with was very hard. The emotional stress on the family, especially my wife, who, you know, you think cancer, you think of the worst things. So that was a major issue to deal with, and the not knowing. We didn't know where the cancer was. It was first thought that it could be in the prostate. It could be anywhere in that line. So it wasn't until I had the TERP done that we found out that the cancer was in the lining of the bladder, and my urologist removed it as much as he could. I had a shocking recovery because I woke up with 3 litres of saline solution being pumped through me, and it seemed like if that ran dry, I was in excruciating pain. So I was a pain to the nurses right through the night, because I could see the container getting lower and I would be buzzing them to come and change it for me, because yeah, and that night I don't really think the nurses quite understood the amount of pain I was in, and I have a very high pain threshold. And one of the nurses on was fabulous. The next one that came on during the night was not so. Perhaps because she had a lot more patients to take care of, was in a private hospital setting. Yeah, it took me another 24 hours before I was fine enough to go home. So, and then started with the oncologist then from there.
So you had some chemotherapy, azacitidine, docetaxel, which can also be given. Was that intravenous or into the bladder?
Straight into the bladder.
Each one
separate. Yep, each one separately, held for an hour and a half, then vacated, and then put the next one in for an hour and a half. Rolling myself around on the table during that period. Very uncomfortable, very difficult.
Yeah, so, okay. And any pain during the process or pain after the process?
Not really. It was uncomfortable. I felt a bit sick, but the side effect I had was that I had to keep eating all the time. And strangely enough, I was putting on over 1 kilo a week in between treatments. So I just couldn't stop eating. Don't ask me why. I don't know. And I'm still trying to get rid of it. So,
wow.
Yeah.
Interesting.
Wow. Yeah. But the BCG has been fine.
Okay, so you haven't had any of the classic UTI type symptoms of needing to run to the toilet frequently, or urgency that you must pee now, or burning when you urinate?
Yeah, the frequency, the urgency, that is around. I've just become, it's part of life at the moment. I'm in that fold right now where recently I had some green light laser surgery done on my prostate, and that was 4 weeks ago, and I'm still got blood in my urine, and I still can't hold on, and I start BCG again next week, so it'll all come together.
How long have you been getting BCG for, Richard, and how much longer do you still have to go with it?
Okay, I've had 2 full rounds of over 6 weeks. and then there's usually about a 3-week interval before I have a TERP done by the urologist to check things out. And I've had one lot of maintenance treatment now, and now I'm about to start another 3 weeks of maintenance BCG, and that I should have another maintenance before Christmas, and then I'll have another TERP done, and then I'm presuming the maintenance will clear out, because this whole thing has been working for me. I'm one of the very lucky people, I think, that
Yep.
diagnosed
Right.
very quickly. I didn't wait around. I had private health cover, so I didn't have to wait for a public opening. Here in South Australia, in the city, I could be waiting up to 6 months for an appointment to see a urologist at the hospital. So, yeah. And whereas I got in just over a week. So I think of that, I'm finally getting back the money I've been paying for all these years into private health funds, and they're paying for it, so that's good. Yeah.
Oh, that is good. No, you're right. Look, there would be a priority if anyone knew that there was possibly a bladder cancer. We wouldn't make anyone wait 6 months. Bladder cancer is prioritized because of the risk involved with progression and how quickly it can spread. But yes, Richard, thanks for sharing your story. And interesting point. I'm sure you all noticed Richard's cancer started not with blood in the urine, which is what we commonly think. Not all bladder cancer starts with blood in the urine. You can just have symptoms of a UTI, and that often just gets treated and sometimes missed, treated with antibiotics a few times and left and not investigated any further. So we like to drive home the message: any change in your urination that's not improving and going back to the way it was before is a serious sign and should be investigated further. So Richard, the thing with this non-muscle invasive and getting this topical treatment, this is what I was saying, it's ongoing. There's continuous cystoscopy checks. There's going for that treatment to have the BCG put in. And at the back of your mind, you're always sitting with the possibility that it might fail. And there's always a risk that you may have to go for the major cystectomy surgery. What are your thoughts? Does this bother you, Richard? Does it play on your mind?
Well, it does, and it plays on the family's mind as well, especially my wife. As we know, there's members in our group that we speak with once a month that have had some shocking results come back after being clear for a while, and it's in your mind. But at the same time, I've run across a few people, because I'm always advocating for bladder cancer wherever I go now, and I speak to people, and I spoke to a guy just last week in Queensland said to him I had bladder cancer. He said, "Oh, I had that twice. First time was 17 years ago, and then I had another back 11 years ago." He said it's a pain in the backside. He said, "But I'm still here." And he said, "And I've had 2 heart attacks, and I've had," he starts listing all the things, and he says, "But yeah," he says, you can never forget about it. And I think that's true. We can't forget about it. The worst thing, I think, for patients is the waiting time to get results from things. It's that not knowing period, which is the most psychologically damaging to us. But
Yes.
I'll live with it and keep going and keep checking on it, and yeah, that's the thing. But I consider myself very lucky.
That's a very common theme we have with our bladder cancer community in our support group is anxiety and the waiting for results. That waiting causes a lot of anxiety. And that's the nice thing about meeting every month. We can try and allay some of that anxiety amongst ourselves and checking in. And we have Facebook groups. We have there's an online presence community as well between our support groups where people can catch up. There's another Facebook group as well. We'll tell you a bit about these later. So yeah, it's all about talking. We just set up a random stall at a market that opened up where I lived in Ryde on one Sunday morning. We set up a stall there, and with us, standing a picture with our brochures and the banners, and people stopped by to come and find out. And we had at least 5 or 6 people, random people in the public, just coming to tell us either they've had bladder cancer or have it, or they know someone or a friend or a family member that has it. 5 or 6 people in that morning that we were out there in just a random part of Sydney. So it's definitely there, and the more we talk about it, the better. There was a question that came in about green light laser, and I'll answer that. Was it for the prostate? Yes, it was. Richard had to have, he's still got his prostate. He hasn't had it removed, so it's obviously enlarged, which occurs with men as they age. Natural enlargement, BPH. So he had a green light laser to open up a channel so he could pee better. As one of the treatment options that are offered mostly in private hospitals, although some public hospitals have it too. Yeah, so it seems to have worked well. He says he's had good results. Okay, I know the others are anxiously waiting by, but before we get to them, there's a poll, everyone, just to make sure all our nurses are awake. So I'm just going to launch it now quickly. We want to know, have you ever who's managed a patient for BCG? The poll's open, so you can give us your results, and let's see how many of you have had to manage a patient with BCG. I'll give you a few seconds to respond. Maybe another 20 seconds. 45% of you have voted. It's under polls. You just have to say yes or no. Make sure I do the right thing here once the results are in. Okay, another 5 seconds, and closing the poll and sharing the results. So 45% of our people or nurses in here have actually given BCG to patients, which is interesting to note. All right, so I'm now going to carry on and hand over to our next patient. I can't remember the order. I think it was Peter first. Peter had the muscle invasive type, so he's the other arm of the staging, and so he had muscle invasive. Peter, do you want to tell us where you're from?
Good evening, all. As I'd like to concur with Richard, with all the oncologist nurses and staff, the physiotherapists, as I call mine, physioterrorist. They've all been great on my journey. I live in Penrith in New South Wales. I'm 69, and in August 2017, I found blood in my urine. My wife, Trish, and I then started our journey to the GP, then to our urologist, where they stuck a fire hose down where it shouldn't be, and it was found that it was stage 2, stage 3 in the muscle. When we were told, Trish was with me on the whole journey, and I should point out now that the partner should never be forgotten. They're on the journey with us, whereas we're going, we know what's happening with our journey. Sometimes they're in the background, not really knowing, how we're, what's happening. So always remember to keep the partner involved. I had 4 rounds of chemo.
Peter, before you go on, how did you feel with your diagnosis? Like, what went through your head?
My urologist sat us down. Trish was with us. If I can, 12 months ago, I just wouldn't accept it. And when the urologist told me, I said, shit, where do we go from here? What are my options? And he discussed it up front. And he said, look, the best way is to have it removed. And he then explained about a neobladder or the stoma. I went with the stoma with my little sporran now. And it was a shock. I didn't know how to tell the family. We had 3 daughters and 3 grandchildren. And my parents are still going. So it was hard to know where we're going to go from there. But we said, that's it, we're going. When we're going to do it, and I said, just get rid of it. I don't want to be chasing it for the next 10 years. So he agreed. I underwent the chemo, and I think they used White King, Rinso, WD-40, whatever else they could find to put through me. And the cancer nurses where we underwent the chemo were absolutely awesome. We became a family, if you like, stage one of our family. My background is defence. We have a defence family, and they become our cancer family. And then the doctor here in Sydney, they have a group meeting. So it's all the urologists in Penrith, all the opposition, if you like. They meet once a week, once every 2 weeks. Urologists, oncologists, radiologists, they all sit down and they discuss their patients. And it was decided that mine was to have the surgery. And while I was undergoing the last round of chemo, my urologist rang me and he said he was dumping me for his colleague. And I said, why is that? He said, he's better than I am, and he does robotic. So after the chemo, I then had 9 hours robotic surgery at Macquarie in Sydney, Macquarie University Hospital. And the staff was in there, were awesome. The stoma nurse, I still remember her. She was as hard as nails and was fantastic. Absolutely didn't take any crap from me. And she taught me how to change my bag, how to do everything else. The physiotherapist, Sally, she was awesome. Got me up and walking, and I was home within 5 days. And on the 5th day when I got home, I ended up in the Nepean Hospital with sepsis. So it was just before Christmas. So I had one round, come home, I was home on Boxing Day. The day after Boxing Day, I was in again with sepsis, and I was in there for 10 days, and they pumped everything else through me. And after that, we became good. Trish was alongside of me, introduced our grandkids to Papa's wee bag. We've been up front. If anyone asks me questions about the bag, I don't know hassles. I'll talk to them, talk to anyone.
Peter's quite amazing, actually. When he arrived in our first face-to-face meeting, out came the bag. He was showing everyone, even when we were out in public at the market, it came up to the top up. He's not shy of his bag, which is quite amazing. You know,
you've got to have a sense of humour, Kalli.
Yeah, but it normalizes it. You're right, but it also normalizes it, you know, for people to see it's okay for people to have a bag.
Well, you got to watch it because our youngest at preschool, I picked her up one day from preschool, and she's in the classroom, and I picked her up. She was 3 at the time, and she said, "Have a look at my Papa's wee bag." And she's pulling up my jumper to show all these little babies. I said, "No, wrong place." But they've accepted it as normal.
Yes.
We went overseas 6 months after the surgery. Unfortunately, last year I started to get a few infections, and in the kidney, and I had it removed in December. It wasn't due to the cancer. There was no cancer. I was part of a trial at Macquarie. As a matter of fact, I had another CAT scan this morning, so I'm waiting on the results. And I don't know about how anyone else feels, but I always dread the CAT scan. I just, you know, you're positive and everything else, and about a week before the CAT scan's, oh, bugger me. You start to worry a little bit. But I'll get the results tomorrow, and I have an appointment with the oncologist. My urologist sacked me last week. He doesn't want to see me anymore. So that's a good sign. But as with Richard, I'm ex-defence, and Defence are paying for all my DVA, Department of Veteran Affairs, are paying for all my chemo, all my surgery. So I've been very lucky that way. So, but life is good. I got a new perspective on life. I changed my bag every 3 nights in the shower. I go swimming with it. I had the prostate removed and 36 nodes as well. So he didn't want to muck around. He had a good margin. So we just go on from now. As I said, Trish has been awesome. The kids have been awesome. The partners are great. I think that's about it.
Peter, so I mean, it must be quite nice not having to go to the toilet the whole time through the night with your bag. You just connect the night bag and then no worries.
Well, see, that's a little bit different. I couldn't use a night bag. I got up.
Okay.
You know? And now I've only got one kidney. I can sleep all night.
Wow.
So, and no, I get up. I couldn't use a night bag. It just wasn't. I couldn't get comfortable with it. So we get up and I'll go get back into bed and fall back to sleep. So, and proper naps in the afternoon help.
Thank you so much, Peter. We really do appreciate you sharing your story. Yeah, what I wanted to say, a lot of patients who have maybe gone sort of Richard's route and had a lot of intravesical chemotherapy and their bladder lining, you know, is not quite the same, and they're just troubled. They have troublesome bladders, and then when they have the surgery and put a bag on, they don't have all those troubles anymore, having to go to the toilet all the time, and the burning and the symptoms and the urinary tract infections. Their life actually becomes, all the catheters, their life becomes a lot simpler with the bag. Some of the women in our group enjoy being able to stand and pee like the men. So yeah, there are positive things that can come out of these experiences that we don't think of as healthcare professionals, but that's why this is so useful to get these perspectives of the patient. Now, I'm aware of the time, and it's all right if we go a little bit over, because Christine's story is important too. And I really want to thank Christine in this public forum. You know, she's really dedicated her whole entire life to bladder cancer and BEAT Bladder Cancer. It's almost a full-time job. She keeps our charity going. She does a lot of work at home till all hours of the day and night, running our social media, the website, organizing things like today, fundraisers. So, you know, she's gone and just taken this cancer experience and made it just something so positive and impacted on the lives of so many other bladder cancer patients. So thank you, Christine, for being by my side. We co-facilitate the group together, and I couldn't do it without you. So on that note, Christine's young, as you can see. She's female, not usually a demographic that's affected classically by bladder cancer, and she'll tell us a bit about her background. Christine, go ahead.
Thank you, Kalli. What an amazing introduction. Thank you so much. As Kalli said, I'm Christine, and I'm from Sydney. I have a husband and 2 daughters, and I was diagnosed with muscle-invasive bladder cancer in May 2017, and at that time I was aged 49. My 2 girls were teenagers. The eldest was about to sit her final exams for her last year of school, which is a stressful time, as a lot of people would know, in any household. So to add a muscle-invasive high-grade bladder cancer diagnosis onto that, all I can say is that the stress levels in my household at that time were incredibly high. My diagnosis came as a complete shock. I was fit, I was healthy, I'd never smoked, I'd never worked in an industry using any chemicals. I had absolutely none of the risk factors associated with bladder cancer. The first sign that I had that something was wrong was that I had blood in my urine. So of course I was like, whoa, what's going on here? And I immediately went to the GP, who diagnosed me with a UTI and gave me antibiotics. So I came home, I took the antibiotics, and I really thought nothing more of it. I felt completely fine. About 2 weeks later, the blood came back. So back I went to the GP and got some more antibiotics, different type this time. And I was slightly more concerned, but I thought, okay, we've got this under control. But unfortunately, about 2 weeks later, again, the blood came back. And at this time, I knew that this was more than a UTI, and we needed to investigate further. So I was sent for an ultrasound, and they did an ultrasound of both my uterus and my bladder, and they found a 2-centimetre tumour in my bladder. I was then immediately sent to a urologist for a cystoscopy. They also did urine tests, and my urine tests came back clear of any cancer cells. So I had the cystoscopy, and you know, after the cystoscopy, the doctor walked into the room and said that you know, the tumour was a different shape to what she expected it to be, but not to worry. You know, I'm young, and you know, this is unlikely to be you know, a muscle invasive cancer. But once the pathology was done, it came back that it was high grade and muscle invasive. So really, I was sent then to another urologist who put my case before a multidisciplinary team, and they said that as I was young and fit and healthy, that I would be a good candidate for a robotic surgery and also a neobladder. So
Christine, what was some of the things going through your head at this time? Sorry, how were you feeling? How did you take all this information?
Well, you know, I was sort of really in a state of shock. And, you know, I didn't feel unwell at all. As I said to my family, on the day of my surgery, I could have run, you know, a 10K race. You know, I did not feel unwell at all. So I was in a state of shock, and I sort of didn't really know where to go. My family started looking for information for me as to what this all meant. What is this neobladder? You know, what is the best way to handle this? We had a daughter doing her last year of school. The whole thing, it was quite a blur, but luckily for me, things moved quite quickly, and basically the solution was to remove the bladder as quick as possible, so that to prevent anything further from spreading. Now, just like Peter and Richard said, every patient has scan anxiety. So they scan you, and you know, you're thinking, oh gosh, has it spread? Is this going to be okay? It's incredibly stressful. So when they say that, I can completely relate, and I know exactly what they mean. But for me, because it all happened so quickly, it was almost like I was on this path, I was on this journey, and I knew that I wanted to live and give myself the best opportunity to be cancer-free. So I didn't really have a lot of time to contemplate what life was going to be like without my bladder. All I knew is that I needed to do this to give myself the best opportunity of seeing my girls grow up and you know, and keep participating in family life. So it was really only 4 weeks from my diagnosis to when I went into hospital to have a radical cystectomy. So they took out my bladder, my uterus, and my lymph nodes, and I chose a neobladder as my urinary diversion. And that is where they take a section of your bowel, which is about 50 centimetres, and they form a new bladder. It was done via robotic surgery at Macquarie Hospital, and I spent 10 days in hospital. I was really lucky that I didn't have any major complications during the surgery or after the surgery, and I had an amazing medical team and urology nurse. And I remember the day after my surgery, which was about 8 hours long, the nurse says to me that they were going to get me up when the physio came and that I would be walking that afternoon. And my initial thought was, no, I think I might just lie here and preferably don't touch me. And they said to me, you know, you need to do this because this will assist in your recovery and it will make the next day even easier. And sure enough, that afternoon, there I was out of bed and I was walking to the doorway, and they really were right. It just made, you know, the next day just that little bit easier. you know, the first 4 days after the surgery for me were the worst. And then after that, I started to feel a bit more like myself, and felt like, you know, I could see that I was making some progress. So for me, it's been 4 years now. I have regular scans and blood tests every 6 months, but so far everything is all clear.
Christine,
So I now,
tell us about the neobladder, because not many people have heard or nursed anyone with the neobladder, seen anyone. What's it like having a neobladder?
yeah, so well, I call it my new normal. And you know, if you were to look at me, you would not know that I've had this major life-saving surgery. I pretty much do everything that I did before the surgery. I can do that now. The one thing I do is I make sure I drink plenty of water during the day, just to keep everything flushed and flowing. Before COVID, I was going to the gym several times a week, and I now just do workouts from home. But I'm able to do that. I do find if I do, like, you know, a long and a lot of jumping, my neobladder can leak. I've travelled about 4 months after my surgery. I travelled overseas. I can swim. I've gone skiing. So basically, I can do everything now that I could do before the surgery. I'm really
Christine,
lucky. I don't have to self-catheterize.
Mm. Do you feel when you need to go to the toilet? Like,
I can. I get that feeling of being. I get a feeling of being full, or of pressure on my pelvic floor. So I know when I need to go. I don't self-catheterize. I did have to self-catheterize for about a week once I was released from hospital, just to make sure that I was able to empty my neobladder fully. But since then, I haven't had to self-catheterize. Sometimes I find it easier to empty than others. I find that if I'm nice and relaxed and I'm not rushing or trying to do it too quickly, then I find it much easier. But if I'm in a pressure situation and trying to go quickly, then I find it a little bit harder. What I basically do is I relax my pelvic floor muscles and I use my abdominal muscles to empty the neobladder. It's not perfect, it can leak. I do have to get up usually once a night, but you know, not always. To try and prevent this or to help this, before I go to bed, I make sure that I fully empty my neobladder as much as I can. But it's also dependent on how much I drink in the evening and even what I drink. You know, for me, it was a fantastic decision. I live my life as I did before, and I can participate in my family's life. So I'm very happy with the decision of a neobladder.
Christine, thank you so much. And just for the sake of time, we do need to wrap things up. It really feels like we could have had a documentary here this evening, and if only the TV channels would accept that this cancer was important enough to put on TV, we would have had a really great show that we could have put on here. Honestly, we're so grateful to you all for sharing your stories. We had a question that came in. Did any of the three of you have to ever consult or choose to consult a clinical psychologist?
Sorry, what was that?
Did any of you see a psychologist on your journey?
No.
No.
No. Okay, so
Yes.
okay. There we
Yeah,
go.
well,
we have a yes. You don't have to tell us details if you don't want to.
I'll just quickly, I actually suffer from anxiety and panic attacks. So the psychology part of it was to help me get through those panic attacks, having the treatment. Yes.
Did you find, and was it helpful? Did it help? Richard? Oh,
Sorry, I can't hear you, Doctor.
Oh, no, oh, sorry. I was saying, did you find the sessions helpful? The psychology, was it helpful? Maybe, I don't know if it's me or Richard. Anyway, Helen, I just wanted to ask you, we've spoken about all patients that have had, curable cancer. Some patients have advanced disease. Is there any special or specific considerations that you have to take into account for patients with advanced cancer?
Yeah, so
Cancer
obviously,
right to the bone.
sorry.
No, that's all.
Me?
Yeah, go ahead.
Yeah, okay, sorry. Yeah, just briefly, just obviously there's no cure for those patients. It's dealing with all it's life limiting. So, there's a end point for these patients, but also I guess now things are changing as well in that space. So people are living a lot longer with advanced bladder cancer. So they are with the immunotherapy now that we're giving. But I guess the consideration is that patients are living longer. We don't know what they're living with because we've never been in this situation before where people are living a lot longer with advanced disease. So I guess we're still working our way through that, and often with the immunotherapy they can end up with chronic diseases as well from the immunotherapy related things. So some people end up with diabetes, so they're living longer with maybe more chronic diseases. But it's just understanding that it's that area of bladder cancer now is changing dramatically. It's gone from it was pretty much you've got a few months to now that's going out to a good couple of years with these immunotherapy treatments. So
when do we call in palliative care, Helen? When do you think is a good time to say?
Look, the earlier the better. The research out there is that if people are involved with palliative care at diagnosis of advanced cancer, they will do a lot better than patients that aren't linked in with them. So it could look out even a year, 18 months out from what you think their survival is better, because everything gets managed a lot better, and palliative care have a lot more resources for community support, and also talking about the things that need to be spoken about where people want to be, what they want to do, the things that they want to do before they may. I'm sorry to talk about this, but it's a reality of bladder cancer for some patients as well, and talking about things that they want to do. So making sure that they're doing all the things that they want to do before they get to a point where they can't do them. So earlier the better to palliative care. Yeah.
Thanks, Helen. Yeah, we won't dwell on that because we've had a lovely positive note the whole evening. But yeah, it's just aware for our nurses to know when it's good to call, because the palliative care can do amazing things, and you don't even have to be dying to get palliative care. The palliative care team, they also come with a lot of experience for managing pain. They're experts in pain management, so there's many benefits, but as you said earlier, rather than later. So I just want to round up and thank you all the participants for staying with us and joining us and sticking to the end. We appreciate it so much because these information sessions just help to raise that awareness of bladder cancer. We just want to end up by saying, please email us your physical address. We'll mail you these brochures that you see over here. Join our Facebook group. We often post information in the Facebook group. We have a social media presence on Twitter and Instagram. This is another Facebook group that many of our patients are part of as well for Australia and New Zealand. That's our Twitter and Instagram information. Please like us, please follow us. Like everything we do, follow us. All those likes add up and just help with our visibility and get our name out there. And again, that's our email address. So for you to send your physical address or to ask us any questions you ever have about bladder cancer, we have the networks, we have the resources, we're able to link up and find out. If we can't answer it, we can get the answer for you. So it's been a great evening. And once again, thank you to our patients for their expertise and sharing their journeys, their very personal journeys with us. We can stick around for a few more questions, but yeah, that's all I have to say. Thanks, Chrysta, again for the support.
Thank you, Kalli. No more questions in the chat at the moment, but a number of nurses chiming in with thank you so much to our speakers for, giving us the patient perspective. It's often missed sometimes in education, and it's really great to hear. And thank you for your openness with sharing your stories tonight.
Thank you.
Yep, I agree. You can also put your physical address into the part where it says questions. So you are welcome, because we'll record your physical addresses from there, and you can send out the brochures. Also, there's a handout section where you can grab the PDF files. If you click on handouts on your panel, we've got 5 PDF files there that you can download onto your computer right now, and print them off and use them in your workspace. So that's there. Otherwise, it's all on our website, or an email to Christine, and she'll get it to you as soon as possible. We'll give it another minute or two, but we're well over time, I think, already. Is anything any of you want to say? Helen, Peter, Richard, Christine?
No, just thanks for the opportunity. It's good to put the information out there. I'm always up for a chat, you know me. So if any of the patients or anything need to have a chat, feel free, go through Christine or Kalli, and I'm there.
Thank you, Peter.
Oh, one more thing. If you have a chance, they're going for a bag, suggest to the patient that he actually wears one, or she wears one, before they have the surgery. Because mine's out by about 2 millimeters. It's a bit late. So wear the bag to see where it's comfortable, so it doesn't interfere with your golf swing, or your cooking or anything else like that. Because the surgeon, they do mark it, but have them wear it for a couple of days beforehand so they know where it goes.
That's a good point, very practical point. And the other thing about it is that it just helps you get used to it, mentally used to it, and also how to work the locking mechanisms, or, all the bags are different, of course, but just to get used to it. It becomes your friend as you've got a name for it?
No, it's my sporran.
Oh, that. Yes. So, okay. I think we'll call it a night. Oh, there's a meeting, survey. Don't forget to fill out the survey. We'll send it to you in your mail. Please complete it. The feedback's very useful for us, so we know how to improve on future sessions. Thank you all. Okay.
Thank you. Good night.
Night.
Thank you.
Good night.
Bye all.